So I'm a PTSD researcher, but also a meditation researcher. I should say I'm an MBI researcher who would like to do meditation research. Um, so I'm working at PTSD for a while. This is one of our early papers, sort of showing differences, and we weren't regularly saying things like, default mode network and dorsal attention network and frontal parietal these days, but we do now. So the default mode network looks like there changes. Actually, so PTSD actually shows a decrease in the strength of default mode connectivity and sort of some intrusion of salience network. So the salience network is much stronger, not surprising, and there's a desegregation. And those all work we done 10 years ago. And there also appears to be some differences in PTSD. This is Robin Opperly, who's now at Laureate, between the frontal parietal network and the default mode, or the anterior default mode. There appears to be deficits. So one way, so the whole, whole ton of research suggesting PTSD has lower default mode network strength, increased or aberrantly increased the salience network, and not surprisingly, but also decreased central executive frontal parietal and connections between them. And so I just drew this cartoon, which I use a lot, the showing the salience network of these big red blobs, and sort of these thick arrows are sort of, too much connectivity, particularly with the anterior default mode network. And the frontal parietal also shows decreased activity overall, but importantly, less connectivity with both anterior and posterior default mode network. And so in terms of thinking like in a, experimental medicine, like where's the target? What do we want to do to try to change something? Well, these are some targets. Can we strengthen the default mode? Can we strengthen? And probably that's hard to, actually anterior default mode. I mean, I normally think of it as sort of the default mode as sort of spontaneous thought, maybe something that, we have a little bit too much of, maybe something we need to regulate. But the anterior default mode, particularly ventral medial prefrontal cortex, is really important in safety and safety signaling, and also in connectivity. And, sort of the whole, Julian Thayer and et al. Has this beautiful work looking at VMPFC and the parasympathetic network. And, and then we have people like Steve Porges, who I'm going to talk about. So it gets a little loosey-goosey, I think, at times. But this idea of social connectivity, really important, and being able to, have that available to us. Well, as PTSD, we know that. Yeah. They're hypervigilant all the time. They're really not able to connect, and they're not. And a lot of patients, I'm a clinician, a lot of patients I work with, have built these avoidant strategies. So they go for years, never slowing down, until they're in their late 50s and they get laid off from their job on medical leave. And then the PTSD comes back floridly. It's like it picks up where it stopped at the end of Vietnam. It's really weird.
It's interesting that you get the VMPFC involvement, because there was a recent study from my last group, basically, that the grain in representations in VMPFC, it seems very linked to the capacity for perspective taking. So it seems like if you had a very rigid or stuck in, it can affect also how you perceive what emotions you project onto others, which can affect your relationships, right? It seems like very much a hallmark of PTSD.
Yeah. Right? Is it often comorbid with depression? Or no? Because it seems
it's interesting. So here's where it gets complicated. We made I used to tell a joke. We get the PTSD team get together. I saw a really unusual case this last week. They had PTSD and no comorbidities. So it's about 40 to 60% comorbid.
Interesting. And then you still see this this decrease.
It gets complicated. Here's where it gets weird. So also cortisol goes completely opposite directions. People with PTSD, some people with depression tend to have heightened levels of cortisol and flattened diurnal curves. Most people with PTSD have blunted morning cortisol. They're flat and they're flat.
Oh, interesting.
So it's like depression is like this, PTSD is like this. But people with PTSD and depression also tend to look more like PTSD in that particular regard.
Okay.
So it gets complicated. So one very simplistic thing is to think, well, if these network strengths are diminished or impaired, how can we strengthen them? That's a very simple-minded way of thinking. And this is also harking. This is also sort of hypothesizing after the results are known, to be fair. Because here's what we found. And this is just sort of some evidence that different types of psychotherapies for PTSD do different things in the brain. Of course, there's also different sites, so who knows? Present-centered therapy is sort of a non-specific form of problem solving with a good, nice person, sort of getting some safety, feeling like I can talk about my problems, as opposed to cognitive processing therapy, which is much more like cognitive therapy. It's really focusing on your symptoms, thinking about them, doing things. Well, they kind of have different things. Let me talk about mindfulness-based cognitive therapy and sort of one of the reasons why. Well, again, sort of my maybe a bit of revisionist history. I started with MBCT because I liked it, and I learned. I was studying with John Kabat-Zinn and folks, in 2005, and sort of really I was a student of Kevji Gaelic Rinpoche at the time, or really my whole life, and I previously studied with Zen teacher. So I was very interested in meditation, how meditation might be put into forms of psychotherapeutic or stress management things. Well, so MBCT, mindfulness-based cognitive therapy, is just really amazingly helpful for people for relapse prevention. It's better than nothing at all, better than treatment as usual. It's also better than antidepressant medication, which is really interesting. In other words, if you give people continuous meds, or you take them off their med and you give them an 8-week MBCT class with 4 boosters, the people on MBCT are doing better 2 years later. So it looks like there's something important about the skills of meditation that people learn that actually helps prepare them for relapse in terms of depressogenic things that happen and spiraling down. So they do better. And the people who really do better on this here, so the people who do the best for MBCT, this is just showing the effect size versus the relative risk for depression. People with the highest relative risk for depression MBCT has the biggest effect. And this, might be, well, yeah, regression, whatever. This is a big deal because normally these people with the highest relative risk tend to become chronic and treatment refractory. So really, these are the people that nothing works for. And these are also the people that MBCT works for. So, and who are these people? Well, they usually are people with childhood trauma. So people with childhood trauma, something about meditation. So this is where I like to, I made this sort of pitch because people say, oh, meditation. Yeah, that's for, that's for people in Santa Monica.
They're not wrong, but still.
My life is easy. No problems. Upper middle. It's like, no, I say meditation. Yes, it is for them. And it's also for people, some of your worst, hardest patients who've had the worst lives, who've really been abused. They actually very often, not everybody, but can be helped by these. And I don't say meditation, I say mindfulness. So what is mindfulness? It's really developed for relapse prevention, for depression. We decided to try it in PTSD for some various reasons. It actually kind of looked like it worked. We did a pilot study. This is again 10 years ago at the Ann Arbor VA. These are mainly Vietnam veterans. We got some movement in these people who are chronic. And you say went from about, it was the clinician administered caps, PTSD score, the old caps, which had a range of 0 to 130. So you see they're up at 80 or 75. So these are pretty chronic, very symptomatic people, and we decreased them significantly. Didn't cure their PTSD, but it made a big difference in their life. And those 8 weeks. So I got funding actually from the Army, which was very interesting, from the CDMRP, or congressionally directed, research program. To basically decide, I can't find the acronyms escape me always. But basically we did a very simple thing. Is we compared I wanted to give our best shot. So we took mindfulness-based cognitive therapy, combined it with basic psychoeducation about PTSD. So all the stuff that you do in a general PTSD treatment without exposure, no exposure, and then did some in vivo exposure, meaning that was, so we wanted to have a step back. I forgot, I didn't put it on the slide. So there are some really effective treatments for PTSD that nobody wants to do, that actually people run from. And they're really difficult, prolonged exposure, even trauma-focused CBT for a certain extent. And I'm kind of making a bit of fun of it. They actually can be really effective for certain patients. But for the patients I was talking about, the patients who have childhood maltreatment, difficult lives, maybe have some, not great attachment, and they have maybe some decreased ego strength, heavy duty, let's talk about your trauma every week, listen to it on a tape recorder every day. It doesn't work for them. Whereas some people it does work for. So I wanted to test a treatment that had no trauma. We never talk about trauma at all. But what we do is we talk about your life. We talk about things that you do. Go to the grocery store, and also do some meditation, and also do some loving kindness and things like that. And we compared this to a VA derived, because present center therapy, really well manualized, beautiful treatment that also is trauma, that does not have any trauma exposure. So what we found was not completely, this is not statistically significant in the between groups, but we saw a large effect size in the meditation group or the mindfulness-based exposure therapy, not much of an effect size in the other group, which is actually normally what groups look like. So our finding of a relatively strong effect in a group is unusual. Then we looked at the brain. So remember I showed, So we did brain scanning before and afterwards. And like I said, I had resting state. Well, I had a bunch of basically emotion regulation, sort of a James Gross, Kevin Oshner reappraisal type tasks and some faces and a bunch of different things. Published a couple of papers on it. We got some moderately interesting results, but the really interesting results were the resting state, which is through in. And what we found using a PCC seed, was posterior default mode network, we saw a large increase in connectivity. There's just a whole brain seed based in the DLPFC bilateral. And importantly, this was actually an ANOVA, so an SPM12. So it's a group time by treatment interaction. And you can see it pretty clearly. So before the treatment, nobody had any connectivity. After the treatment, it was the MBCT group or an MBET group, and not the not the normal talk therapy. It also was correlated with some symptom remission. So that's suggested. Right? It looks like a real phenomenon, or at least we thought so. So this is our study in 2016. This is Judd Brewer's data in long-term meditators. So this is cross-sectional, not pre-post.
So interesting.
It looks exactly the same. And I thought I called Judd. I forget. We call them. Jesus Christ, they look identical. And but ours is a longitudinal trial, and it's with PTSD patient. Well, then also David Cresswell at Carnegie Mellon saw the same thing. Tammy Crowell working with Richie Davidson saw the same thing, and so did Danella Hefferman. And this is with adolescents. So we've got long-term, lifetime meditators, PTSD patients, unemployed people in Pittsburgh, and Danella Crowell's, Danella Hefferman's adolescents. So it looks like something's going on with mindfulness. If you do mindfulness for a certain amount of time, we see a change in the PCC in particular. This is the strongest effect. I put seeds elsewhere, by the way, of course. So we looked at INSIL, looked at VMPFC. There were some changes, but not as reliable. And so I start to believe this now. It's replicated 5 times. It's like, well, maybe something. So I should say also, I'm very interested in putting all the data together and sort of seeing what happens.
Can you just maybe take one step back before I interpret this in my head of what the implications of all this is? What exactly is the common practice like in the mindfulness? Can you just go over that again? Like, what is the how long? Like, I know it's an 8-week thing, but what does an actual session look like? Is it more akin to like a focused attention, or is it open monitoring? Is it body sensation? Is it?
Oh, you're so right. It's all of the above.
Okay.
That's what I say. It's not really it. So it's very manualized, and it is at least the mindfulness-based cognitive therapy. It actually starts with much more. It starts with the raisin exercise, which many people do. The sensory, you eat a raisin really slowly, you pay attention to it, you close your eyes, and this is just what John Kabat-Zinn's doing this since the 70s, really. And many of you, I don't know if it was Dan Goleman or. But it's a neat exercise, and it basically shows people when you bite down on that raisin, it's like, boom. There's this. Have you done it?
No.
Oh yeah. Oh my God.
Yeah.
We had some
It's a
raisins. I
classic,
passed them out. It's classic. But it's an idea of just watching. So what this does is it focuses on sensory input. So it's really bottom up. It's paying attention to senses, not interoception. Interoception is hard, actually. So we start with taste. Taste is relatively easy, or smell. And really focusing, 20 minutes or 15 minutes on the raisin, and then importantly 15 minutes talking about it. What did you notice? What happened? So I always say, what did you notice? And when people start talking about their experiences when their grandma baked a cookie, I say, oh, very interesting. But what did you notice now? Tell me about,
Mhm.
so that was a memory. So there's a training or end training of what's called mindful inquiry, which is focused on helping people, this is a teaching, really helping them, inviting them to bring their speech or they're talking about their sensory experiences, which is hard actually, because we don't normally do that. So anyway, so the raise and exercise and the body scan. There's 3 weeks of body scan. Body scan, we do the sort of classic lying on your back, focusing. Then we start a 10-minute mindfulness of breath sitting. Then we'll do some yoga. Okay, or hatha. I don't call it yoga. I'm not a yoga instructor. Who's a yoga instructor here?
Not an instructor, but
Yeah.
I practice a lot.
Yeah, I mean, I like it, but I'm not an instructor. So I don't call it yoga, I call it stretching. And it's the same thing. But really slow. And then so the first week is really about the introduction and body scan. Toward the third and fourth week, we're starting to introduce the idea of seated mindfulness meditation of the breath and interoception, sort of breath body. And then for the next 4 weeks, it's more, we shift the focus. So breath, body, sounds, thought, emotion. So over a 20-minute, which is very long, 20 minutes for novices is very long. And then we start introducing the idea of open monitoring. So it goes from a very sensory-based to a breath-based to kind of more open monitoring-ish. But I don't use those terms. I don't say shamatha. But it's actually pretty robust in the sense of it's manualized and it's sort of it's accessible. Most people can do this.
Gotcha.
But that's why I say it's not one type of meditation.
Okay, but there still is there an emphasis in these later stages on like the acknowledgement of self-referential processing of the stimuli and trying to bring attention back to the sensations?
Yes.
Okay.
Yes.
Okay. So then these
Yeah,
results make
exactly.
perfect sense.
Exactly.
Okay.
Yeah. So the idea is, okay, so now, you just noticed you've caught yourself and thinking, oh, let me show you another result too. So this is what I believe is related to once you recognize sort of that you're off, or purposeful volitional movement of attention toward an object, in this case, the breath or the interoception. But we also have some, I'll just cut ahead. I'm also very interested in sort of the similarity and differences between interoceptive processes and metacognitive processes. They're related, but they're different things. Maybe we can disentangle them. They're both important to PTSD and depression and anxiety and everything else. And guess what? Sort of therapies for all these problems also use interoception, or they use metacognition, or they use both. And this is from Antoine's beautiful sort of interesting review of meditative practices, so that some of them are 5 dimensions, I think. So meta awareness, object orientation. So see, focused attention is where mindfulness really starts. And this is very effortful. And it's not particularly meta aware. But then we're moving from, and of course, 8 weeks too. This is brilliant. So in 8 weeks, moving from more of a focused attention on senses to more of an open monitoring and metacognitive sort of awareness, but also having the focused attention as an anchor, like you can always come back to it. And that's really important because, so anyway, this, maybe I'll talk about it. So this is, I'm also very interested in the so-called, well, actually, difference between effort versus effortless. Right? If you talk to TM people, where they say, oh, it's effortless. I'm not even, my meditation is superior because I don't have to do anything. Well, I guess the Dzogchen people say the same thing. Interesting enough. And so do Soto Zen. I always mix it up with a dirty word. Just sitting, just sitting.
Yeah.
Or these Chinese forms of empty the mind, and you don't have to do anything. As opposed to something like my teachers in the Gelugpa tradition, they actually have a lot of effort, and they talk about you really have to do forceful, effortful ability to actually just to calm the mind, to bring it onto an object, and then as you get more and more skilled or experienced, then the effort starts to decrease, but you have to start with effort. So this is not a new question. I mean, actually back to the famous debate between Yaokan Shansu and Hunang, whatever, I don't speak Chinese, but there was this famous, the 6th patriarch of Zen defeated like the guy who was obviously the pinnacle of Chinese Buddhism at the time, by saying, no, it's actually, you've got it all. Like this will take it, scholasticism or whatever is not right. You really just have to meditate. And by the way, Huineng was illiterate. And this guy was like good buddies with the emperor,
Mhm.
you know. So supposedly Huineng won the debate, but it's unclear. But this, you know, it's also kind of a hagiography, sort of backward looking. So the Zen people really like Huineng
Mhm.
because he said things like, well, there is no mind. Where would dust delight? You know, there's really more of a Madhyamaka esque. But also in Tibet, you know, 75 years later, we have a very similar type of debate, right, between Kamalashila from India, who also talks about making effort, gradual, with activity. You have to build up sort of your capacity to then at some point be able to sort of throw everything away. But you have to actually device, artifice, effort that all is important. Whereas again, the Chinese master, he said, no, just forget about it. Just empty your mind. And he left his shoe. Does it say that there?
Yeah.
Vanished from Tibet, left his shoe.
Left the shoe, yeah. Well, that was considered a famous omen.
That's great.
What's that?
I didn't know that was an omen.
Oh, in this case, because they kicked, so there was a famous, the king of the emperor of Tibet he says, I want to know what type of Buddhism we're going to practice.
Mm.
So get the best Chinese person, get the best Indian person, get them to debate. And the Chinese, the Zen master lost. So he had to basically got kicked out of the country, vanished immediately. But he left his sandal, and that was supposed to be an omen, that sort of a trace, whatever the good essence of the Chinese system remains.
Love that.
And so again, it's hagiography, sort of just so stories. But this is very important for the development of Chinese Buddhism and the development of Tibetan, Indo-Tibetan, because the Tibetan Buddhism is really much more focused, much more oriented toward the Indian tradition. And Kamalashila, as well as other great, Indian masters, and Chinese Buddhism sort of, which became Zen, but also many other different flourishing forms of Buddhism, it kind of did its own thing, and had its own flowering. So back to your question, Nico, what is going on? So this is Wendy Hasselkamp. You guys, if you read Wendy's work, she only has 3 papers only. And they're brilliant papers. And unfortunately, she dropped out of science.
Oh, really?
Yeah, well, she's mind and life. Like she's more of an administrative.
Okay, cool.
Yeah, and she's wonderful. But she did great papers, small with Vipassana and meditators. And so when she broke down, I credit her. This is obvious though, in a sense, right? We know what happens. Well, how you start meditation by mind wandering, or you can start anywhere. Let's say you start with focus. Okay, my breath. I want my breath. Breathe in, breathe out. What's for lunch? What am I doing? Oh, I'm gonna go surfing. Oh, wait a second. So there's focus. Then there's mind wandering. Then a very important thing happens. It's awareness of mind wandering. Right? We become aware. We have a meta cognitive awareness that we're not on our focus anymore. Then what do? Then we have to purposely shift, and then we go back to our focus. So and then it's a cycle. Rinse, repeat 1,000 times. So this is also, Fox and Wakel's famous paper, the default mode versus the task negative mode versus the task positive network. And we can think about what's it?
I said that was a classic.
Yeah, exactly. I always have to show it because the data are so amazing too. If you look at the blue lines, the red lines. So we can also, there's one way of thinking about mental activity. We can think about it. There's many ways to think, but one way to slice the nature of the joints to think, well, there's sort of stimulus dependent external. I'm focusing, I'm playing basketball, I'm doing my talk. And there's internal thought of like, I'm thinking about what's for lunch and like, what am I going to do next? And these things go back and forth. So episodic memories, future projections, mental time travel, spontaneous evaluative automatic evaluation of situations, which can be positive or negative. As a psychotherapist who sees a lot of people with depression or PTSD, it usually tends to be bad acting, right? Here, your default mode is not a good actor. It usually is doing something not very helpful, but it's important to recognize that it's there for a reason, I believe. And as opposed to, stimulus dependent or task dependent types of things, we have this activity. We're always toggling back and forth. And of course, if you believe, I'm spacing this out, funny. Anyway, so there's different executive attention, alerting attention, Nobel Prize. Anyway, Posner. And Kahneman too, to a certain extent. But Michael Posner sort of had these different types of attention, getting us between these different modes. Well, here's one sort of overly busy representation, but thinking about my thinking of, how the salience network and the frontal parietal network sit in between these different, between like the default mode and different subsystems, and then the sensory attention or a sensory devoted, task oriented, but in between. So if we go back to our original thing, if we're going between, sort of focusing is really about attention networks, whereas, stimulus independent mind wandering is about default mode, but we got to go between them. So the alerting attentions, which when you're playing basketball, you're supposed to be playing basketball, and instead you're daydreaming, you get hit with something, boom, you got to get back. Whereas there's also top down, effortful, effortful is more sort of the frontal parietal network or the central executive network. So how does that relate to meditation? Well, it's sort of the same. When you're focusing, your attention networks are online, you start to mind wander, you become aware of it. Importantly, what happens here is the insula and the dorsal anterior cingulate are really important in this process.
Yes.
And then, so once there's a startle or this alerting attention, this error detection, then you bring online frontal parietal network and attention network. So it's a very simplistic view of what might happen during meditation. And do we have data for that? Wendy actually had some data for that, which was pretty cool. Can we use our data? Well, remember, what are we looking at? Default mode and frontal parietal network. We also saw, hang on, this is just a follow-up. So I replicated the study. And actually we saw the same thing, which is pretty cool. Replicate whole completely new batch of people.
Can I ask?
Yeah.
So since it's cool, since you're describing it as a dynamic process, I wonder if fMRI is too slow for this, but like some of you compared with EEGs, like I wonder, could experienced practitioners track the relative temporal frequency by which they do cycling, and could you model that and see if you actually see this sort of like these macro network state transitions in a way that's
really
time locked?
Yeah.
So I think so. So this
Should be
is
something
this is
phenomenal
looking
to
at weeks. This is looking at weeks.
Right, of course.
Yeah,
Right,
so
right.
this
I
is
was
a
curious,
pre-post. However, there's been some real-time fMRI work, and then of course Judd's work. We were using both real-time fMRI and EEG correlates. This idea of trying. So I think he would primarily try to decrease PCC activity.
PCC,
Yeah. But there's also at MIT. Gabriele Whitfield, Susan Gabriele Whitfield. So she's been doing some really interesting stuff as well. In addition to decreasing PCC, which I think is easier with a real-time fMRI to get the signal.
Yeah.
And I was also trying that at Michigan before I left. We're actually trying to look at a real-time calculation of a connectivity coefficient, basically, between PCC and DLPOC. Now, one of the problems is that I think it's all a little bit different. And so in terms of the heterogeneity between subjects, so you have to do kind of some mapping ahead of time, and they get individualized ROIs.
Right.
But that's what I would love to do. What may be also even easier is PCC to dorsal anterior cingulate. And that is, Haley Roderick, who's now at Richard Davidson's lab, did this nice meta-analysis, just a literature-based meta-analysis, but PCC with dorsal anterior cingulate, right within that error detection, the salience network. And this was, and my study was also, so this is my study, and we see actually the same. Well, obviously, it's part of a meta-analysis. You should see the same thing. But we say very nice, and I replicated it too. It's actually a little bit more. It's ACC more in DMPFC for some reason. I don't really know why. We're in the process now of going back and pre-processing everything, and then doing a joint ICA to come up with these individual level maps, so that we can hopefully get more rather than sort of putting everybody in the same brain space. But here, the reason I'm showing this is because what I'm hoping is that this aspect may be more tractable. So either looking at, in terms of the whole network, people haven't looked at the whole network altogether, I don't think. But we have, Judson's been looking at decreased PCC, and Susan Gabrielle Whitfield's looking at sort of also decreased PCC and some dorsolateral prefrontal cortex. We tried to do that, didn't get it. My next step is actually, this is just seems a little bit easier because the dorsal ACC is a little bit more volume constrained. You know, it's not like the frontal lobe where you've just got everything everywhere. So that would be, I mean, what do you think?
Well, I think because if you're talking about four macro networks that sort of purportedly cycle among each other, and you could think, okay, maybe we don't parse the whole network, but what would be nodes that would maximally differentiate between those? And if could you have look at experienced practitioners, and could they give some kind of online monitoring of like their speed of their cycling or even manipulate it? And could you see this stable transition? Could you model a stable transition between macro states? And see if that's more consistent in an experienced practitioner versus an
Probably
inexperienced
do
one.
that with the EEG fMRI study. That way you're demarcating as a
Yes.
function of the
And that's
EEG
exactly what Wendy,
signatures,
Yeah.
that's what Wendy did, but not with every,
Mhm.
she basically just had people press the button when they noticed they were mind wandering.
Right.
Mhm.
And
Well, even if it was
very
just
simple.
2 points in the cycle, because right, if it's a
Yeah.
cycle, you're passing through it.
Yeah.
So if you just have someone go like every time you notice, oh, refocusing.
Yeah.
And because you can't like mark when you lost your focus unless you're really good, right?
Yeah.
Like, yeah.
Right.
That'd be really
Yeah, so
interesting.
Wendy just went back 2 seconds. And so
Right.
that must have been mind wandering.
Sure.
Yeah,
Yeah.
we have our paradigm is
It's like
similar to
that,
the
okay.
spontaneous emergence aspect.
Gotcha.
Lovely.
Interesting. Yeah.
And so I'm really interested in that. So I've
Mm.
not really pursued it further. I started to do some real-time fMRI and then moved my lab. I now have an EEG. I'm learning EEG.
Mhm.
And so, yeah, so I'm interested in trying to replicate Judson's paradigm and something else more. I'm also particularly interested in frontal theta
Mhm.
and how that comes online and maybe doing some tests.
Have you looked at all also like I always say this, but I feel like at every lab, but like complexity based measures?
Starting to, I mean, just things like overall.
Because there's like degree, if you look at like the
Network
entropy of
efficiency.
like the
Entropy,
degree
yeah.
distribution, right? Like I think Zidell, I know a student of Zidell's who showed that the degree to which you show a change in that is predicts the exchange of the extent of meditation induced analgesia, suggesting like it's a measure of how much you're breaking up or changing or restructuring sort of representative structures, right?
Yeah, I'm actually trying to. I had one of my analysts working, not my psychoanalyst. He's working on it too.
Sure.
Why did they go to this field?
Yeah.
No, he's so she's trying to replicate some of these entropy measures, but
Oh, yeah.
haven't done it yet. So I'd love to talk with you
Yeah.
and think about how, and especially have you done it?
We've done it on a couple of data sets. And I know that this is my colleague, Alex Diamant, who we used to work with, but he's shown that because you could speculate like this, some of Nico and my work, you could speculate that it may be some findings don't generalize because what is being changed from one person to another for PTSD is more sort of a rigidity of a given structure. And that structure may differ among people. So it may not show up in univariate statistics, but then if it's the change in structure, if you're extrapolating in terms of
some higher
complexity
level,
feature, the higher order
Yes.
features, that would show among participants as a relationship of the degree which they, their PTSD ameliorates, right? Because PTSD, that might be why it perpetuates depressive symptoms in a way that's persistent. It's not like you can change any number of, linear knobs on their brain chemistry.
That's
But
right. You have
they
to look
have
at the whole
they have a
thing.
maladaptive structure that perpetuates itself, right? And you have to disrupt that self-perpetuating structure. And that might be why meditation is so important for these refractory patients who are where their depression comes from.
So
trauma,
yes,
rather than oh my dopamine tends to be low because of a genetic difference. Or something.
no, I very strongly agree with that. And that is exactly what I think is happening. That there's a structure of looking at the world,
Right.
which is defensive.
Yeah.
And which
course.
is served a very important purpose,
of course, yeah.
life and death.
Yeah.
So it's very preserved in a sense, and it is protected.
And it seeks to perpetuate
And it
itself.
yeah. And it makes people miserable. But
terrible,
evolutionarily speaking, it doesn't matter if you're miserable.
Mhm.
Right? You just have to live long enough to procreate.
Right.
And make more miserable people.
Yeah.
Yeah, and we see that in the So I'm also fascinated by this idea of intergenerational transmission
Mhm.
of childhood maltreatment.
Oh
and
yeah.
adversity.
Oh yeah.
And it does come. And if you talk to people who are perpetrators, they say, "Why was it was for their own good? And I had to teach them a lesson.
Right.
The world is a hard place,
Right.
And so this idea. So I really love the way you described that as sort of a structure. And I was talking with some friends too about whether we could do some sort of a PCA based thing, not a whole brain PCA, because obviously you pull out,
Right.
the big networks. But is there a way to do a theory-based PCA
Right.
on this kind of self-referential, this maladaptive,
Right.
defensive ruminative,
Right.
miserable structure.
Yeah.
Yeah,
Because you may find, and you're finding that already, you may find like if you look across all people who have these things, they maybe there's one or two connections that are consistently stronger for all of them. And that'll show up
Yes.
in these univariate things.
Yeah.
But it may be very likely that there's a heterogeneity in what their rigid structure is.
That's right.
You can extract a feature that measures the rigidity
Yeah.
or measures
yeah.
how much it changes in response to a
like
treatment,
path
even if
efficiency, all these graphs,
Yeah.
like between the centrality of the PCC.
or just like reorganization, change in degree distribution.
Exactly.
Because
yeah.
your maladaptive thing might be different than
Exactly,
mine.
yeah.
That's right.
But we should both show a change in
Sure.
certain features at a second order
Exactly,
as
yeah.
as a function of meditative,
Yeah.
as a function of meditation affecting our depressive symptoms.
Where the first
Right.
order could very well look
Super
Different,
different.
that's right.
Yeah.
That's
Maybe
right.
I'm hyper focused and you're like hyper avoidant.
Yeah,
I don't
yeah,
know,
yeah.
like some
Yeah.
shit like that. Yeah.
that's
Yeah.
that was a big impetus for like writing up the personalized approach to meditation
Yeah.
piece that we wrote.
Oh, interesting.
Yeah, I'll share with you.
Oh, love that. But
Yeah,
I
the
think
equivalent
it
of
is what. Oh, sorry.
No, that's all right.
I do think that the fact that there are these sort of self-perpetuating rigid structures
Right.
that are lifelong or that are learned early in life
Yeah.
and that continue to show up in your adult life.
Yeah.
This is why I think meditation is helpful or
Absolutely.
mindfulness is helpful
Absolutely.
because you can actually see it.
Yeah.
So one of the jokes that I tell, but it doesn't work. You have to be of a certain age. I work a lot with elders too.
Mm.
I said, do you remember Jimmy Carter and Ronald Reagan?
Mhm.
All right. I don't know. Oh, maybe I'm okay. I'm probably older than everybody here. So Jimmy Carter and Ronald Reagan had a debate. And obviously Jimmy Carter was brilliant
Mm.
and he was a skilled debater and he knew everything. Ronald Reagan was a doofus,
Yeah.
but he was charismatic and he did have a certain human connect, he had a certain sophistication of how to read a room. And so the question was about something policy. Nobody remembers the question. And Jimmy Carter was, well, here's what I'll do, and here's why, and this is what. And Ronald Reagan won the debate by saying, "There he goes again."
Oh. Boy.
Wow. Yeah.
Boom! It was gone.
Yeah.
He just destroyed him. And so I say you can be Ronald. I say connect with your inner Ronald Reagan. When your
Right.
mind starts going off, you say,
There he
There
goes.
you go.
Yeah. That's true. Yeah.
It's so